Okay, I'm done. That was enough, yeah. So what do y'all want to talk about today? Fantasy football, anyone? I am 5-1, woo! It won't last, I'm confident. I'm really thrilled to be with y'all here again. It's a gorgeous day. Have you been outside? Oh my goodness. But if you're gonna let the dog out at 5:45, might be better not to try it in your boxers. I won't do that again. I am in a position right now where I am concerned about a few things, and I'd like to raise your awareness of some of the things that are concerning me today about the health insurance market in Louisiana, specifically the small group healthcare market in our state. If you're not aware, we always like to talk about Louisiana as a small company hive, right? Here in Louisiana, we grow small companies at a volume you just wouldn't believe, and they are crucial to the economic development of the state and their ability to make offers of good salaries and benefits to our children coming out of college is critical to our ability to retain those talented young men and women in Louisiana. And you may or may not know, we've got a net outflow of people right now leaving Louisiana faster than they're coming in or being born. And so I want to show you some things that I think may be contributing to that, things that are going to be particular areas of focus for us over at Blue Cross over the next few years as we go forward. So the next time you hear me or someone else talking about this stuff, you'll already be an expert and you can impress your friends at parties. Cool? All right. I want to introduce you, if you haven't met him yet, to one of my heroes. As an economist, I have 4 or 5 guys who've gone before me who've done amazing work in the field of economics. Dr. Walter Williams, who sadly passed away last year, was one of those trailblazers. What really got my attention was we had a bank of forecasts that he had made over a 10-year period, and 88% of them came true. Now, if you can forecast in the world of economics at an 88% clip, you can name your price. But it also means that you have embraced the real world, at least a little. And what he said in 2017 at a conference I attended, when he was asked about healthcare and healthcare costs, was this: the one thing we've done magnificently in the United States of America is we've managed to build a world-class, technologically advanced healthcare system that none of our citizens can afford to use out of their own pocket. Let that sink in for a minute and you'll understand what comes next. So, you know, following that line of reasoning, I did a little research. I don't know if you guys can read this or not, but I thought if someone's trying to self-insure in this day and age, you know, we talk about that now in the property insurance crisis. We talk about people maybe self-insuring their homes up to a certain level. Could you do that for your body? Could you be a self-insured health person over the long run? Well, here are some sample prices, cash prices, for different procedures here in Baton Rouge. I did this survey this summer among a lot of the people that we have network relationships with, and I averaged them out. And so you can see an ER visit for a hairline fracture in an arm or a calf was about a $6,000 visit if you didn't have a third-party payer backing you up. If you want to use GLP weight loss drugs, Wegovy or Zepbound, to lose weight and you're not a diabetic, you can count on that running you about $12,000 a year just to have that medicine available to you. You want to talk about delivering babies, right? We have one of the foremost delivering babies hospitals in the nation right up the road here on Airline. Between 12 and 25 grand for a normal newborn delivery. I'm not talking about a C-section here, all right, normal. When we talk about my favorite old guy injury, how many of y'all play pickleball? Anyone? Nobody. Look, they won't admit it. I love it. As a carrier, I can tell you that we are experiencing an increase in injuries of the Achilles tendon and anterior cruciate ligament from older folks above the age of 50 who listened to their foolish friends who told them, hey, you could do the same stuff you were doing when you were 30. Don't slow down. Keep on playing tennis, pickleball, whatever you were doing. Well, the average ACL repair is running about 68 grand right now by the time you put in the physical therapy and everything else you need. And you can see on my list some of the things: knee replacements, an air ambulance ride for 45 minutes, runs between $50,000 and $70,000. If you have kidney failure, God forbid, and you have to deal with a transplant, that can easily go over $1 million in a year. My point in showing you all this is our system is not designed for you to pay for it yourself. It's just not. If you don't have a third-party payer in your back pocket, or you have a friend or a family member who's not enrolled with a third-party payer, please discourage them from trying to self-insure their health. Because one of two things will happen. They'll either go bankrupt or they won't get access to the latest and greatest treatments, one or the other. And we want to avoid both of those things. Everybody cool with that? All right, let's move on. Let me talk about small business in Louisiana. This is a recent report from the U.S. Small Business Association about specifically the state of Louisiana. In 2022, they counted over 470,000 small businesses registered in the state of Louisiana, and in this case, small is 100 employees or less. Everybody with me? 100 or less. 470,000. 392,000 of those had no employees. They just had an owner, and that was it, or a sole proprietor and a spouse, but no technical employees. 68,000 of them had between 1 and 19 employees, and 10,700 of them had between 20 and 100 employees. This group of businesses employed 52% of the Louisiana workforce, more than half enrolled in these small businesses. Now, what I can also tell you is from my own scans, and my best guess right now, is that about 22,000 of these total offer a group health plan today. So even if you look at the 68,000 that had 1 to 19 and the 10,700 that had from 20 to 100, about 22,000 of these businesses are able to offer a group health plan to their employees. That number when I joined Blue Cross 20 years ago was almost 30,000 groups. So the ability of small companies to offer small group plans, or the necessity perhaps, is shrinking over time. And so let's take a little bit deeper dive into that. When I talk about a fully insured small group block at Blue Cross, the average group size is 6 employees. 6, that's our average. So we've got to go back in time a little bit and have a short history lesson if we want to understand what's happening to small business right now when they try to offer a health benefit. In 2010, when Congress passed the Affordable Care Act, it rather arbitrarily defined a small business as any company that had 50 full-time equivalents of labor on a regular basis or less. That could be a combination of full-timers and part-timers. Once you added it all up and you got to 50, you were out of the range of a small business. Why did it matter? Because in the small business world, you have the option of not offering health benefits without any federal interference. So if you're a small company and you decide, I can't afford to offer a group health plan, I'm just not going to do it, there's no penalty for that. But if you're averaging 50 full-time equivalents labor or above, and you don't offer a group health plan, you could be in line for very large fines. And you can tell anyone who's running a business that size or larger or works in HR that they've got immense amounts of reporting to do. Every time an employee says, I don't want your health plan, you've got to document that in writing. It is an enormous amount of paperwork just to prove to the feds that you don't need a $1 million fine or a $2 million fine. And we help groups with that every day. But we're here mostly to talk about small groups. Small group coverage is optional at the federal level right now. It's at the whim of ownership. And that's really the good news for investors. The bad news is that in 2010, Congress took the authority of control over small employer plans and individual plans away from the states and centered it in Washington in a federal agency that was created on the spot called the Center for Consumer Information and Insurance Oversight. You may hear the insiders call it CCIO. If they say that, they don't have a lisp. They're actually naming a federal agency, CCIO, right? Now, CCIO has got an enormous amount of authority. In fact, the tri-agencies, as the fancy folks call them, Treasury, Labor, and HHS, have issued over 100,000 pages of regulations just to tell CCIO what small groups and individual coverage is. And these regulations are evolving. They're not done. We get another 200, 300, 400, 500 pages every year as they try to apply a political solution to what might actually be a financial problem. But, you know, I digress. Included in the power, if we take, well, Mike, okay, they created this agency, what can they do to us? Well, it's what they can do to us and then what we do to you, right? CSIO sets the annual cost sharing, deductibles, co-pays, co-insurance. They set all of that on small group and individual plans. They approve every single plan that we sell has to be approved in a federal system before I can sell it to you if you're a small group or if you're an individual. We have to put all these plans in this federal black box, and then it comes back and says, oh, we like that one, we'll call that bronze, or we'll call it silver, or we'll call it gold, or nope, you can't sell that anymore, you need to move all those people onto something else. We literally go through that process every year to try to make sure we stay in compliance with CSIO's rules. Even setting medical loss ratio limits. Now, this is a fancy word, and this is what it means. If you give me $1 in premium, how do I spend that dollar? What do I do with it? What percentage of that dollar did I spend on nothing but health care? The federal law says in the small group world, at least 80% of the money that you invest in premiums with us can't be spent on anything but health care. We can't pay taxes with it. We can't pay salaries with it. We can't pay for 8 regional offices with it or advertising. We have to spend it on health care activity. The upside of that, when you get down to the bottom of your balance sheet, is that sets the premium. That number, that medical loss ratio plus healthcare costs, determines how much you have to pay for coverage. And it is a federally specified algorithm that we battle every year. Now, in the years I've been at Blue Cross, we've seen actions that have happened that weren't intended to damage the small group market, but have drained good risk, healthy, younger people out of the small group market in droves over the last 25 years. The first one is CHIP. You might remember in the 1990s, we expanded Medicaid for children of age 2 to 19. It's a very generous program. The income level for qualifying for CHIP is over 200% of the federal poverty line. It's a high number in a poor state like Louisiana. But of the 800,000 kids that were invested in CHIP by 2015, at least 100,000 of them were good risk, young, healthy kids who would have been enrolled in a small group plan, but are now in a federal program, so their good risk vanished out of the small group market and into the Medicaid program. Likewise, in 2016, when we expanded Medicaid again to include adults up to 138% of the poverty line, another 600,000 people moved into that program. Around 80 to 100,000 of them were very good risk, healthy young folks who came out of the small group market as well. And so you can see you've got this risk pool for these small companies. It's deteriorating and being drained of its best risk year after year after year. And the effect has not stopped. Now, the IRS and the CMS in 21 and 22 made more huge changes in the forms of a whole lot of borrowed money, $350 billion over 10 years, to enhance the attractiveness of the individual market and to change the way small group markets deal with dependents and spouses. I'm going fast, I'm sorry, I want to make sure you get to work on time. Let's go and take a look at this graph and take a breather. Everybody take a breath, take a drink of water, good? Let me say there are no official sources that can nail these numbers down. If there was, I'd have bought it by now. Doesn't exist. So this is my best guess as to the 4.6 million people in Louisiana today. Who is the third-party payer that represents them when they get sick? And you can see about 36% of the population is currently enrolled in a Medicaid program. If you look across to the other side, about 19% of us are in Medicare. Now, when you add those two numbers together, math's not my strong suit as an economist, but it's around 55%. Louisiana has the highest percentage of its population enrolled in government programs of any state by a mile. We're at 56%, the next closest state is about 42%. So what does that mean? Well, what it really means is when these folks go to seek care, if we look at the general financial situation for hospitals or for doctors who are treating these patients, that's almost 60% of us who are buying care below wholesale, because the amount of money Medicaid and Medicare pay for care is literally below the wholesale cost of care. That means somebody else has got to fill in the gaps. And if you're a privately insured person, whether you're on Aetna or Cigna or United or Blue Cross or OGB or a self-funded program, you are filling in those gaps with your premiums. You are compensating the hospitals and doctors for the monies Medicaid and Medicare don't provide to get their care up to cost, to wholesale. And you need to be aware of that because it affects the expansion of coverage, it affects legislation, it also affects the premiums when you see increases and stuff like that. Everybody cool with that? That's a lot to deal with all at once. Y'all are doing great. Nobody's sleeping, nobody's throwing stuff at me, I feel better. 20 years ago when I walked in the door at Blue Cross, a very bright man named John McGinnis, who was our director of communications at the time, said, we have got to show our people, as a not-for-profit, locally owned insurance company, we have got to show our people what we did with all the money they trusted us with. They deserve to know. And so he came up with this idea. Essentially, what you're looking at is the income statement of $2.5 billion of premiums that were taken in 2004 when I joined Blue Cross. And so in 2004, that $2.5 billion was spent thusly. 38% of it paid a hospital bill. 34% of it paid a doctor visit or an outpatient services bill, you know, like labs, imaging, PT, anything done on an outpatient basis. 11% of it paid for every drug our members used in the hospital, at the clinic, at the pharmacy, and it took 17% of the money coming in to run our business, pay our taxes, pay commissions, pay salaries, do IT upgrades, compliance costs. All the overhead in the system was 17% in 2004. Anybody want to see what it is now? No. Who said no? You're hired. All right, welcome to 2023. The numbers are a little different, right? See if you can spot the differences. Yeah, I'll go back. I'll go forward. Anyone? Drugs, baby. Look at that. 29, and this, by the way, premiums are now almost $5 billion. So the amount of money coming in the door has doubled, yet we still see pharma getting 29 cents on the dollar of every dollar of premium you pay. You want to talk about a train. And people say, well, I hear my family, they complain at me if they have to pay a $30 copay for a drug. They're like, I have health insurance, why do I have to pay for the drug? And I thought, yeah, that's a great question. So I looked in our books from a couple of years ago, and for these same members, we bought $950 million worth of drugs, almost $1 billion. And the total amount of copays and coinsurance they had to pay was 12.5% of the total. So in other words, insurance covered almost 88% of the cost of all the $1 billion worth of drugs our members used. If you ever want to get a shock of your life when you pick up your meds, ask them to show you the retail price. It's usually on that white piece of paper they give you. It'll rip your head off when you see it. But this is the battle we're fighting today. Hospitals still getting about the same amount of money. Docs, they're very unhappy with the amount they're getting. Primary care is under-resourced. Why? Well, you can see where the money's going. Now, I will tell you a secret. Shh, don't tell anybody. I gave a speech to a doctor's organization out of state one year, and I showed them this. And they were very angry at me. They were like, we used to get 34%. You're cheating us. We knew it. Blue Cross is keeping our money. And the only thing, I let them have their moment, right? You got to let people vent. And I said, okay, I've been at Blue Cross 20 years. I have never seen anyone in our building write a prescription. They didn't like that. But we don't really control what drugs people get except by limiting a formulary. Now, in the United States, it is not at all unusual for a regular old Blue Cross plan to have 12,000 drugs on the formulary, right? If you go to the National Health Service in the UK, where everything's free, they only allow about 2,800 drugs on their formulary. Because there's a committee that looks people in the eye and goes, yeah, no, we're not covering that. And they walk away from it. We don't really walk away from anything. We just roll with it. Everybody cool with that? Good? Yeah, I know. I make people so happy when I come to visit. The last thing I want to show you is this. In the individual market today, it's become a direct substitute for small group, and that is not going to stop. Because about 3 years ago, the federal government decided that the amount of tax credits and subsidies people could get on healthcare.gov wasn't sufficient. So they tripled and more the amount of money you can get when you buy individual coverage on healthcare.gov. What you're looking at in this graph is a map of the old system versus the new system. So I have a gentleman, he's 64 years old, he needs coverage for one more year before he goes on Medicare. The premium for the plan he has selected is $1,234.67 a month. If he's on the old plan as a single person, as soon as his income hits $60,000 a year, he's exposed to the entire cost of that plan. He's eligible for zero help when he makes 60 grand a year or above under the old system. The system they put in 21 and 22 is represented by that orange line, that nice smooth orange line going up, where the guy making 150 grand a year is still getting a couple $100 of tax credits. There will be a knockdown, drag-out fight in Congress to continue this authorization because it expires in December of 25. Somebody's got to decide to refund it, and the initial CBO projection is $335 billion of new debt over 10 years if they continue the orange line. But if they don't continue the orange line, about 8 million people are going to get dropped from their health insurance just like that. So it's optics versus debt. Which one do you think will win? Optics. I'm in the optics camp myself. I figure they'll figure out a way to make it go, but we'll see. But can you imagine these small companies that have no employees and they have a single guy who's trying to provide insurance for his family, and he discovers that if he puts his family on this, he can draw down all this tax credit money, and all of a sudden he doesn't have to worry about whether his premium goes up or not. As long as his income doesn't go up, his premiums stay the same. Pretty scary, huh? It's not really an incentive to excel, if you know what I mean. But that's kind of where we are. Now, I have got 12:54 on my clock. I promised the Woodman that I'd be done by 1. And I've got lots more slides, which you're not going to get to see. But I will show you the last one, because it's my favorite, right? It has a little lesson built into it. There it is. Just because you can get your hands on something and you can reach it doesn't mean you should, right? That's Benjamin, and that's my Sony surround sound system. And if he ever finds the power button, he's going to get a big surprise. He hadn't found it yet. But I want to stop right here and give you guys an opportunity to ask me questions. And it doesn't have to be about what we just talked about. I'm a Blue Cross guy. How often do you get to take shots at us? So go right ahead. Going once? Oh, yeah, I knew we'd have a couple. That's why I love coming to Rotary.
Hey, what advice would you give to the companies right around that 50 threshold mark when they approach that?
I personally tell people not to worry about that when you're making business decisions, because you've got to do what's best for your business. And if you dig deep into the law and you hire smart people, you'll realize that you can get a 30-person exemption, which means you could actually go all the way to 80 before you have to pay a fine, as long as you provide an affordable insurance plan under the law. So I don't worry about it. Your business has to come first before worrying about a group health plan, I believe. And I work for Blue Cross, so what does that say?
So my question is this.
Yay.
Nobody likes losing money, especially people who have plenty of it already. So what the law says that MDs and other healthcare providers are sustaining by taking Medicare and Medicaid, at what point will they just stop providing services altogether and we'll have more of a bifurcated health system between people who have private care or concierge medicine and those who are on some sort of subsidized?
Yeah, that's a great, did y'all hear his question? Could y'all hear? He's worried about a bifurcated system. Welcome to it. We've already got it. My other grandson, whose name is Boston, I refuse to call him that. I call him the boss. That's as far as I'll go. Was born 3 weeks ago, and his mom was on Medicaid when he was born. And so the baby is presumptive Medicaid. And so none of the pediatricians on the list of recommended peds would take Medicaid. And the ones that would take Medicaid had a 3-month waiting list. So this is done. This is already, we're in the bifurcated system. Somebody has got to decide that it's not just enough to give low-income folks coverage. You've got to get them meaningful coverage by making sure they have providers available to them. And the only way that's going to happen is you got to pay them a living wage, right? That's what we're talking about. But great question. Thanks for it. Anyone else? Yep.
Pharma.
Yeah, what about them?
I take a medicine, loved by Blue Cross. Thank you.
Yay for us. Yeah.
And it's decades old, it's generic,
Uh-huh.
and how on earth can they still charge $300 a month?
Well, y'all caught her question. Why can pharma charge so much for a particular drug? There are a lot of people involved in setting that price, not necessarily just the drug company. But the answer to your question is because they can. And I'm not being trite. This is America. You can charge whatever you want for stuff. The same Wegovy and Zepbound drugs that you can pick up here, and listen, we can get it a little under $1,000. I promise you can't, right, a month. Those same drugs, if you buy them in the UK or France or Germany, anywhere else, are between $100 and $200 a month. Exact same drug. Why do we put up with it? Because we do. We put up with it. And it's not a good situation. For a non-diabetic obese person, for me to start covering GLP-1 drugs just so they can lose weight if they're not already diabetic, the price needs to be around $300 a month for it to make any sense at all. If it's $1,000, we'll never save a nickel on that person, no matter how healthy they get, ever. That's the nature of the beast. Good question. Yes?
Hey, Mike, I've got 5 employees, and I'm covered under Blue Cross.
Yes, thank you.
Part of my plan is an HSA, part of it is an HMO, depending upon what the client wanted. But my HSA, who I'm personally on, and a low utilizer of Medicare, medicine, I'm getting crushed.
Yep.
I mean, it is off $25,000, $7,500 deductible, and I'm putting money in the HSA, but it's absolutely crushing.
And I'm sorry.
Yeah, what do you do?
Well, you have an agent, I assume.
Yes.
And you have a good agent. You're happy. You love him. You know, ask him for alternatives.
Yeah.
The only thing I can tell you is that the only solution to high healthcare costs at this point, and may I add, this is Mike Bertaut talking, right? Not the Louisiana Health Services Indemnity Corporation, or Blue Cross Blue Shield of Louisiana, or HMO Louisiana, or anybody affiliated with us. If you want me to fix healthcare, I can fix it for you. I need 3 things. Number 1, the authority to tell everybody no. Number 2, the legislative authority to back up my no. And number 3, the biggest Secret Service detail you've ever seen in your life for when I start telling people no. Because that's how the systems that operate at low percentages of GDP, that's how they operate. That's how the UK operates at 8% of GDP, maybe 9. France is at 9 or 10. Germany's at 11. We're at 19. Okay? But somebody in the chain has the authority to say no. The next question is, who do you trust to say no? Right? Me? Aw. That's the nicest thing anybody's said to me in weeks. I think we're over time. Yep, I got 1 o'clock on there. You guys go make money, go to work. And don't forget, check out the blog. It's straighttalkla.com, straighttalkla.com.